So, good evening, doctors and viewers. Today is the sixth day of managing patients post COVID with none other than Dr. Padam Sri Dr. KK Agrawal. And as shared by Dr. KK Agrawal yesterday, that today's topic is very, very important. And he has requested many of the viewers who were attending yesterday that we need higher number of people to disseminate this knowledge of today's lecture. Before we go into the session, I would like to give the winners of yesterday's Witco Fall quiz of the day. The winners, unfortunately, both are from Mumbai. Dr. Uday Kolas from again Mumbai and Dr. Komal Sonawale from Mumbai. Congratulations to both the winners. And with this, I request Dr. KK Agrawal to start the today's very important session. Over to Dr.
Thank you, Anand, and thank you, FDC, for committing to the cause of education of the doctors as far as post-COVID is concerned. In the last 5 editions, we have spoken that 37% of the people may suffer post-COVID manifestations. Today, we will focus on gastrointestinal functions. We will only touch liver, because liver we are going to talk in great detail in the coming days. Let's have the slides. Can I have the slides, Ritu? Yes, can I have the next slide? So these are the points which you are going to learn by the time this lecture is over. The most common presentation of COVID-19 is from cricothyroid to terminal ileum presentation. That means this is upper GI involving the small intestine. Large intestine is usually spared. So I start from the top. The nasopharynx and the oropharynx are common as far as respiratory tract and oro-GI tract is concerned. But when it comes to cricothyroid function, lots of people you will say, hey doc, I'm having something sticky here, something obstructing here. When I eat, something is getting stuck here, discomfort in the throat. This is the commonest manifestation post-COVID. And that is because of cricothyroid muscle spasm. May respond to antacid, may respond to local anesthetic with antacids, may respond to H2 blocker, may respond to povidone iodine gargles. Very difficult to treat. And yesterday we have talked about the word itis, I-T-I-S. Therefore, this virus is an inflammatory disease, can cause esophagitis. Then comes is the gastroesophageal junction. It can cause relaxation of gastroesophageal junction. So therefore, the patient may have severe acid reflux, heartburn, and that can also cause cricothyroid dysfunction because of the acid reflux. Then we have the stomach. So it has a classical COVID flu, COVID stomach, like we say gastric flu. Similarly, we can have gastric COVID. Patient actually may present with symptoms of gastritis, and that may be the only manifestations. Then comes his small intestine, duodenitis, jejunitis, ileitis, ileocecal junction inflammation, and something like COVID appendicitis. Because of the GI circulation, patient may have what is called them as mesenteric lymphadenitis and mesenteric inflammation. Remember, after the cecum, large intestine is usually spared. Now, which are the vitamins which are absorbed here in small intestine? Vitamin D, folic acid, B12, calcium, iron, and that's the reason you may get deficiency of these hormones because the GI involvement may persist for 3 months, which we will discuss. Therefore, these patients may require a long-term vitamin D, calcium, folic acid, iron, B12 absorption for the next 3 months. Therefore, this particular seminar is focusing on the role of iron. So one is the hemoglobin, direct attack on the RBC. You may have low hemoglobin. There may also be a low iron absorption. Therefore, you need to continue B6, B12, iron, and folic acid for 3 months in a post-COVID phase. And that's what we are doing a quiz on Vitcofol, that is vitamin with B12 with folic acid, B6, B12 combination. And that's what we are talking about. So therefore, loose motions. Now coming back to the acute phase, then we come back to the post-COVID phase. In acute phase, if you have loose motions with fever, cough, if you have upper respiratory symptoms with fever and loose motions, take it for granted the patient has COVID. Now, these loose motions, because of the small intestinal ACE2 receptors, can be a direct or it can be due to inflammation. And if it is a inflammatory loose motions, patient may have recurrent loose motions for the next 3 months. The patient will say, my loose motions, the virus has gone, I have recovered, my loose motions are persisting or coming back. These loose motions are small intestinal. Therefore, watery, mucoid, effortless, copious, painless. No large bowel involvement, therefore no tenesmus. You will not have a pain while passing the stool. No blood is seen in the loose motions unless you have a complication with that. Now, couple of anecdotal observations. This is our observation. A, involvement of small intestine without lung involvement may mean mild COVID. If somebody says, I'm having loose motions, we say you are going to recover. So in majority of the times, the reports, international report says that small intestinal involvement is a balle COVID. You are going to recover. Second, most of the time when you are having a family, there are 14 people in a family, and you want to know who is the first one who might have got, look for a diarrhea. If a patient has a diarrhea, probably that patient was the super spreader. The reason being, toilet may be the area where a person is getting the infection, because in the toilet you don't have a proper ventilation. Therefore, their aerosol formation increases. So the patient who has a loose motion means he's going to the toilet again and again, and he is causing formation of aerosol. So we have observed that if you have 5 people in a family who has got infection, the first one usually will be the one who has loose motions, and usually that will be a female. How do you check? Just check for a CT value of RT-PCR. You will find it much lower in such cases. So indirectly, you require a person who is having a loose motions in the family. Ask them not to share the toilet with other people if possible. Rarely you can have a constipation. I have seen 2 patients who presented with constipation in this particular condition. Third thing is, because of esophagitis, the patient will develop heartburn. And heartburn, now you are in doubt whether it is COVID esophagitis, or a patient is developing a thrombotic complication as developing an angina. How do you differentiate? So any chest pain or burning, which can be a burning here, normally person will say, I'm having chest burning, reflex coming in. So if the patient is susceptible, always rule out underlying coronary blockages also. So these two conditions can sometimes mimic. But pain of angina is usually difficult, is usually differentiating. But heartburn sometimes can be very difficult, very difficult to distinguish between heartburn and angina. Both can occur in COVID-19. Famotidine is the drug which has been tried. It also has an anti-cytokine action. PPIs, there is a controversy, do we give it or not? I am giving it, but there is a controversy for that. Now remember, this condition has, how do you differentiate? How do you want to rule out corona? Arthritis, arthalgias, joint pain, corona is practically ruled out. Throat, you say, my throat, I can't speak. Hoarseness of voice, no corona. Mediastinal lymph node involvement, no corona. Pleural effusion and pericardial effusion, no corona. But mediastinal lymphadenopathy, yes, corona. Remember, all lymph nodes in the body, no lymph nodes in the body are involved except mediastinal, except mesenteric lymphadenopathy, and that confirms the GI origin of this particular disease with that. Now, important thing in loose motions is hydration, hydration, and hydration. Dengue, chikungunya, and in this. So hydration, keep a bottle of hydration with you, which has all the electrolytes with 0 calories, and drink it. So you can buy from the market 0 caloric fluid, because you are taking, in this condition, sugar is precipitated. So whenever you are taking in a loose motion, you require a no caloric drink, 0 caloric drink with electrolytes, which can take care of that. Always take care of iron deficiency. And now we come back to the proper slides. Next. So oropharynx and gastrointestinal tract are interlinked. There is a common passage which goes to either the GI or the respiratory. Therefore, we take a formula. And the formula we say is, when the virus enters, so for this, I want to take the slide out. So when the virus enters, virus will go up or go down. If the virus goes up, we have a loss of smell. This is a rough formula to teach to the students and to the public. You say, when the virus is entering in, if virus goes up, you have a loss of smell, balle balle. Patient is not going to become serious. The virus goes in, he has 2 passages to go in, GI or respiratory. If he goes to GI, balle balle, patient is not going to be serious. If going to respiratory, then he may go into seriousness. This may not be scientifically correct because we have no evidence. These are anecdotal experiences with us. So the virus goes up, loss of smell, patient is not going to have severe pneumonia. Virus goes down, chooses the lung, can go into serious pneumonia. But if it chooses the GI tract, patient may not have serious pneumonia. Can I have the slides? Slides. Next. The gastrointestinal tract is vulnerable target to SARS-CoV-2 infection because it has expressions of ACE2 and transmembrane serine proteases, which is called TMPRSS2. That means GI cells small intestinal cells behave like the lung cells, the pneumocytes. Both of them had the, so that if the virus goes inside the GI tract, virus is like a key. It is identifying the ACE locks, and if the ACE locks are present on the small intestine, it will unlock and enter the cell and cause inflammation, production of both TNF alpha and interleukin 6. Next. So GI symptoms have been commonly reported in patients with COVID-19. Everybody knows. But the most important thing is GI symptoms may be the only symptoms in patients with COVID-19. Anupam Kher's mother, anorexia was the only feature. In the family, you will find somebody developing unexplained loose motions may be the only symptom. You may not have respiratory symptom at all. These are the studies which I am not explaining. And they says that 35 to 50% of the people may have GI manifestations, and GI manifestation may be the only symptom. You only have heartburn, you only have loose motions, you only have gastritis. And the only way to explain is my hypothesis that when the virus enters, if it enters the GI, it may not enter the lungs unless you are getting repeated doses of the virus. Next. Now, another thing is if you have both, you have GI symptoms and mild pneumonia. Suppose you have both. In that case, GI symptoms may precede the development of respiratory symptoms. The patient will say, I had diarrhea, and 3 days later, he says, I have started developing cough. Now, this again, in our experience, these are the patients who stay at home and they get repeated doses of the virus. So this time the virus enters the lungs and they may also have a respiratory symptoms. Next. And everybody knows that the virus is present in the stool for up to 3 months, much later than the virus is present in the nose. But does this virus in the stool a live virus, communicable virus? Nobody knows. Gastrointestinal bleeding is an uncommon presentation. It's not common. Why uncommon? Why still it can come? Patient is on mefenamic acid, patient is on steroids, patient is on aspirin, patient is on, there is a gastritis. So you can get stomach and small intestinal bleeding, but that's very, 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 very common with that. Next. There are, now remember, I'm coming here, this is an inflammatory disease. It is causing small intestinal inflammation, and we also have Crohn's disease. So it can mimic celiac, Crohn's, ulcerative colitis. So therefore, sometimes you may start looking at, oh my God, am I going to a Crohn's disease? So it can flare inflammatory bowel disease. It can mimic inflammatory bowel disease. So therefore, every patient with new onset GI symptoms for over 48 hours, rule out COVID-19 first. Rule out COVID-19 first. Crohn's patient will say, I'm having symptoms for the last many years. Next. Next. So what are the proposed mechanisms? Like in every organ, there are SARS, there are ACE2 receptors, there are transmembrane serine protease receptors. So therefore, either you can have a direct virus entering the intestinal cell, hijacking the cell and producing its own proteins, or it can damage the intestinal mucosa or upsets the balance of intestinal flora. Therefore, you require a good hydration, also pre and probiotics in this particular condition. There is no role of any antibiotic. So you give prebiotic and probiotic. and you take a electrolyte non-sugar solution, loose motions will be all right. The loose motion can be 5, 6 in a day, may last for 2 days, 3 days, and after 9 days, it may come again and go, come and go, come and go, depending upon a flare up of inflammation. So whenever there is a flare up of inflammation because of any trigger, the patient may have GI manifestation. Next. So basically, you have a IL-2, IL-6, IL-7, and TNF imbalances, and which can cause diarrhea. Diarrhea can also be because of drug-induced, remdesivir, hydroxychloroquine, and gut flora is altered. So therefore, always give them pre and post biotic, pre and probiotics. Next. COVID and liver is a separate subject we will take. But remember, liver, specifically fatty liver and COVID. So therefore, fatty liver, obesity, abdominal obesity, heart disease, they all are interlinked with COVID and can make COVID inflammation, can worsen the COVID inflammation. Today, we are only touching that COVID and liver are two important things which we need to understand in great detail. Next. COVID and inflammatory bowel disease, the principles are very clear that both can mimic, both can worsen each other, both involves interleukins and TNF alpha. If you are of an inflammatory bowel disease, talk to your doctor. Remember, you can be on two drugs, immunomodulators or immunosuppressant. If you are on immunosuppression, you need to be under a specialist. But if you are on the immunomodulator drugs, COVID-19 may get, the severity of COVID-19 may not occur. Because in COVID-19, you are only giving immunomodulator drugs. That's true for all inflammatory diseases, whether it is inflammatory bowel disease, Crohn's, ulcerative colitis. Next. Next. Now, this is an important. Now it is proven that COVID-19 can cause involvement of liver, gallbladder, that we will talk separately, but it can also cause involvement of pancreas. You can have patients developing very high blood sugar because of pancreatic inflammation. I have seen many patients presenting with pancreatitis. So therefore, there is a pain, check for amylase, lipase. Like a dengue pancreatitis, you can also have a COVID pancreatitis. Never ignore abdominal pain in a patient. Always look for, am I looking for a pancreatitis, which can also precipitate diabetes or worsen diabetes. And next, it can also cause, next, it can also cause necrotizing pancreatitis. I have seen one case presenting with necrotizing pancreatitis. It's all inflammation, nothing more than the inflammation. Remember, there are two types of inflammation in acute and post-COVID. In post-COVID, yani between 9 days and 90 days, necrotizing pancreatitis mean you have multi-system inflammatory disease of the adult. Normally, we say multi-system inflammatory disease of the pediatrics and adolescent, but now it is described in a post-COVID adults also. So for the next 3 months, if you have an acute pain and if you find pancreatitis, look for CRP and ESR and TNF alpha, they may be increased. This may be a pattern of post-COVID relapse of the inflammation. Next. Now, these are general things, and the general formula is when you talk about endoscopy, the general formula in COVID is urgent, emergent procedures should not be delayed. All elective procedures should be delayed. That's common for bronchoscopy, endoscopy, wherever. The principle remains the same. Urgent, do it. Non-urgent, postpone it. Next. And always All patients who are on steroids, if they are on low dose, continue them. They may be beneficial because they may be able to protect COVID complications. On a high dose, talk to your doctor. Do I need to continue high dose or reduce my high dose to low dose? Next. So let me revise before I come back to the question of the day. Ritu, you need to type the question also. These are the choices. Just type it out. In the meantime, let me confirm that when we talk about GI manifestations, they may be as common as respiratory. If respiratory is 60, these can be 40. These may be the only manifestations. And remember, after 9 days to 90 days, 9 to 90 days, GI manifestations may persist. You may have to give a H2 blocker for 3 months. Patients may have recurrent diarrhea. If the patient has recurrent diarrhea, then you need to give him a solution, a liquid to drink which does not contain sugar, because sugar is inflammatory in COVID. Normally, sugar is inflammatory. Normally, we say take ORS. At that time, we say it contains 2% sugar. But here, even that 2% sugar may not be required because this is an inflammatory diarrhea. Anything which doesn't contain any sugar, so we may require a zero sugar electrolyte drink in this particular condition. Sometimes you may have constipation. Mesenteric lymphadenopathy can develop. A patient may have appendicitis, cholecystitis. So don't go for a surgery. These are the cases. First look for patient may have a colicky pain, ureteric pain, which may mimic like abdominal pain. And every time you are having a post-COVID GI manifestation, look for CRP. Remember, the gold standard test is CRP. On day 9, if your CRP is less than 1, chances of post-COVID inflammation are lower. But after on 9th day, if your CRP is higher and you don't tackle that, then any trigger can precipitate recurrent inflammatory conditions. Remember, this virus has two phases, the viral phase and an inflammatory phase. Both are independent to each other. The inflammatory phase can continue after the virus is dead, and that inflammatory phase can get triggered by a new infection, can be anything which triggers inflammation, can trigger that also. Let's have the question of the day. Can I have the question of the day? Yes. Which of the following is suggestive of unfavorable COVID-19 prognosis? Increased red distribution width, which is available on a CBC test. Increased RDW basically means more than 14.5. Hyperferritinemia means more than 500. With that, high hepcidin or all of the above. You can put your questions right away. We are waiting for you. And when you put your questions, our team will select two of them and you will be awarded tomorrow. So I am ending up and back to Anang Basu that GI manifestations are common, may be present in 30 to 50%, 30 to 40% of the cases. And if you have a new onset of GI symptom, rule out COVID, rule out COVID, rule out COVID. Why? This person with loose motion may also be the super spreader. By the time you think, the person may have spread the infection to the whole family. Back to Anand.
Sir, thank you very much because GI manifestations post COVID and during the COVID is itself is a big subject, and the way you have taken our viewers and doctors thoroughly on this session was commendable, and it can only come from Padam Shri doctors like Dr. K.K. Agrawal, and we have a big thank you for this, for making this so simple. At the same time, sir, I want to give you a good news that with this today's session, we have crossed 1 lakh viewers watching us on it, on last 6 days period. So that again is a big achievement for us because you have been continuously working, tirelessly working, and giving your time not only during the practice and post practice, making us making your time available for common public, doctors, for education, and spreading the message, information on COVID, as well as for protection of from COVID. So I think we thank you very much, sir. At the same time, I thank the viewers and the doctors, and I request them again that either they search Dr. KK Agarwal's Facebook page, or they go to Med Talks by Dr. KK Agarwal, or they look into their mailbox which they have registered while logging in. They can find the link there, with Kufal link there, and they can click and see all the previous lectures which has been taken by Dr. KK Agarwal. So at the end of the session, my last request would be that tomorrow would be the day 7. Again, Dr. KK Agarwal will be available with us 8:30 p.m. We request you to be there and spread this message to as many as practitioners you can do, sir. Thank you very much, sir.
So thank you, everybody. Enjoy your dinner and take care. You are precious for us. Prevent corona if you can. If you can't, say to yourself, so what? I'm stronger than the corona. My weight is more than that of corona. I'm more intelligent than corona. My height is more that of corona. So what? I will face it with a strong hand. Thank you very much. We'll be back tomorrow. Namaskar.
Thank you, sir.